So I'm Dr. Benjamin Levy. I'm an associate professor at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. There's a lot that we've learned by using immunotherapy. We've certainly learned about their efficacy, but we're also learning about their toxicities and best ways to manage them. And, you know, it's the typical itises that you need to be mindful of when you're using these drugs, either as single agent, either single agent or using them in combination with chemotherapy, or as using them in consolidation post-concurrent chemoradiation. And I will just speak from my own clinical practice, and certainly my practice probably mirrors the data. But we need to be aware of thyroid abnormalities. Those are common. Remembering to check TSH and free T4 in our patients is critical. We tend to manage those patients ourselves with Synthroid if they become hypothyroidism, but they get hypothyroid, they can also become hyperthyroid. So we need to follow these things closely. Obviously, pneumonitis is a big one. This can happen grade 3, 4 in about 5% of patients, but grade 1 and 2 can happen in a higher percentage. And this is a careful dance that you have to do because patients that aren't symptomatic with just some findings may be able to be treated, whereas others needed steroids and come off treatment. And I would ask that you really partner with your pulmonologist on this. It's really important. I always say it takes a village. Don't be afraid to reach out to the pulmonologist and get them on board to ask questions. I think the other side effects that we think of obviously are colitis and hepatitis. And again, these are rare. Grade 3, 4 adverse events as it relates to these itises are rare. They're around 5%, but there are grade 1 and 2 are more common. And again, it's critical that we partner with our gastroenterologist. And every one of these patients who comes in, who has any of these side effects, we really try to partner with the other disciplines that help manage these. I think the other thing that we've seen is some of the flares for patients with pre-existing autoimmune phenomenon. So we see rheumatoid arthritis flares, patients with well-controlled lupus who can have flares, psoriatic arthritis have flares. This is, again, an opportunity to partner with our rheumatologists. And I think it's too short of a segment to really go on how the nuances of managing all of these. Grade 1 and 2, generally, we can keep on therapy and treat with steroids. Although there's grade 2 and then there's grade 2. I think there's some wiggle room within even one grade. I think when you start thinking about grade 3 and 4, that's when we start talking about taking patients off of immunotherapy, giving them a treatment break, giving them some steroids, and then seeing if they recover and reinstituting the immunotherapy if they have recovered to a grade 1. Now, this is an area of controversy, if I have a patient, as I did last week, who experienced a grade 3 toxicity colitis with pancolitis, her PD-L1 is 100%. She responded beautifully to immunotherapy, but she developed pancolitis, had to be hospitalized for 4 days, responded beautifully to steroids, and now is back to normal. And I think the question is, can you safely re-challenge those patients? And this is an area of debate and discussion and where medicine becomes an art and not a science. So my broad strokes are, 1, look at the NCCN guidelines on this, on management. They're very clear and they're laid out quite nicely. I refer to them all the time. 2, partner with your subspecialists. Hesitate to reach out to pulmonologists, rheumatologists, gastroenterologists, endocrinologists to better understand how to manage these. And 3, don't think that because a patient has to come off of therapy, they can't go back on. I think the data is nuanced and we're learning more about it, but certainly an opportunity potentially for patients who were responding before that you may be able to give them treatment again.